Hello, welcome to Fertility Fact or Fiction, our weekly show where we bring you the latest and greatest in all things fertility and try and break down any myths that are out there and help all of you out who are trying to conceive. And today is a very, very special episode of our show because we have a very dear friend of mine and an amazing, amazing fertility specialist who has agreed to join us from Toronto, Dr. Prati Sharma. She is an amazing REI, also American board trained, and so she's going to be joining us tonight to answer your questions. If any of you have questions targeted to either of us or specifically for Dr. Sharma, don't hesitate to post them. We don't have a topic to discuss tonight, although Dr. Sharma is more than happy to talk about diminished ovarian reserve, which is a topic that's near and dear to both of us and something she really focuses on quite a bit. So, Dr. Sharma, thank you for joining us tonight.
Thank you so much for having me, Rahi. I feel like this friendship has blossomed over the last couple of months. We've gotten to know each other through various conferences and, being seated next to each other and, sort of talking about the evidence around various aspects of fertility. So I'm really excited to be part of your amazing show. I can tell you a little bit about myself, but thank you for the great intro. Yes, I practice in Toronto. I've been Create Fertility Center for the last 14 years. Wow. I, much like yourself, have trained in the US. I trained in New York at Cornell and Columbia universities. And then I met and married a Canadian and moved over here and have been serving the fertility population in Toronto for the last 14 years at Create. My interests include, as you mentioned, diminished ovarian reserve, fertility preservation and egg freezing, third-party reproduction, PCOS and endometriosis, pretty much everything that we like to treat as fertility doctors. At Create, being one of the larger centers in Toronto, we see a lot of second and third and fourth and fifth opinions. There's so many out there.
Yeah.
And we try to really, I try to personalize and tailor my stimulations when it comes to IVF to sort of fit the patient's needs and her reproductive desires. Really make sure that it's the best stimulation that we can possibly get. So, happy to answer any questions that come up and look forward to our discussion.
Awesome. Thank you for telling us a little bit about yourself there. I didn't realize you'd been there for 14 years. Did you go straight from New York to Create and get started there?
Yes, of course, because I look so young, right?
That's right.
Yeah.
Yeah, that's amazing. So right into Create and you got started there and took off with the other doctors that are there. Right?
I did, being from a completely different country, I had no idea about the fertility practices in Canada. Now things have really changed, and I think North America, as you know, practicing on the border, the US and Canada are sort of neighbors, right? And cross-border treatment is so common. But at that time, it was like, oh my gosh, what are you doing going to Canada? So I had to do my research, and Create, being a practice that really covers the breadth and depth of fertility treatment, seemed a natural fit for me.
Awesome. What do you think is the kind of major differences between what you experienced in the US and what you practice now in Canada? Because we do get a lot of Americans actually watching the show, and many of them are actually interested in jumping the border and coming to Canada. I know certainly we're generally a lot cheaper than it is in the US, but what about the quality of the care and the personalization of the care? Do you think it's different between the US and Canada in your experience?
It's a great question. I think that there are a lot more things that are standardized in the US when it comes to the way clinics and networks practice. So I think one of the beauties of clinics like yours and mine are, because we're somewhat independent that way, we're not sort of using standard protocols that might be classic for certain networks, whether that be, CCRM or RMA or whatever it is.
Right.
And so because of that, and I've had this discussion with a lot of my American colleagues, I find I'm able to sort of try new things or talk to and collaborate with people or other colleagues like yourself, like we have at multiple meetings, and sort of go back and say, I'm going to try that. I think this patient would be a good fit for this sort of novel, different, interesting protocol. And so I think that is something that's beneficial to clients that are coming from outside of Canada, maybe in the US, if they want to try sort of maybe out of the box treatments that they wouldn't otherwise be exposed to. So, I do enjoy being able to practice that sort of individualized care that I otherwise might not have been able to at other places maybe in the US.
I think your sound just kind of cut out a little bit there.
Oh, let me push up a little
Oh,
bit.
that's
Is that
better. Yeah,
better?
whatever you did
Okay,
was better there. Yeah, that's perfect. Yeah,
awesome.
yeah, I agree with you totally. I mean, I find that a lot of the patients that I am doing, as you said, second, third, fourth, fifth consults for from the U.S. are really describing what we on the show always refer to as cookie cutter medicine, where it's not individualized. It's just kind of the same thing for everyone. And my firm belief is the same thing for everyone doesn't really work, which is I think where you and I are very much aligned in that regard, because I love the fact that you're saying you individualize, and we talk about how important that is on the show all the time, that you have to individualize the care because obviously not everybody's biology is the same. So it's super important to kind of make sure that you are doing the right thing for that particular patient. Based on their biology, but also based on their wishes. I mean, we get some patients that want, 5 kids, and we get other patients that want one, and you obviously don't need to treat them the exact same way each time.
You
So,
got it.
yeah, I think that's super, super important. Amazing. Is there a particular sort of diagnostic group that you like working with the most? I mean, I know you're awesome at doing, pretty much the full gamut of everything we see, but is there one kind of group that's most near and dear to you, whether it's your cancer patients or your endo or
Yeah.
your DOR?
I mean, it's interesting. I think I actually love the two ends of the spectrum, which is the fertility preservation patients who are coming in because they don't necessarily want to start their family now and they want to freeze eggs or embryos. And I think that conversation is so unique and interesting and sort of making the decision as to whether it is time to freeze, what their trajectory is going to be, whether they would single parent by choice. So that clientele is really important because I really firmly believe in being proactive about your reproductive health. But then the opposite side, the patients that are older, or even if they're not older, but have significantly diminished ovarian reserve and sort of feel helpless, or maybe have seen multiple physicians where they say it's time to move on to donor egg, but they really want to conceive with their own gametes. I think that population where we're like, wow, let's try this new protocol or this new medication, and we get blastocysts and we're really excited about it, that is also super fun. And I think both those groups of patients allow you to sort of individualize your care with the patient, get to know the patient and her desires, and sort of revel in the successes when they work out. And when they don't work out, make sort of those next steps and treatment plans as to where you'll go from there. So I always say infertility is a bit of a puzzle. And it's always kind of fun putting all the pieces together and deciding what the best next step is
Yeah.
together with the patient.
So, walk me through what it would be like for a patient coming to see you at Create. Like, just kind of walk everybody through that process from, I guess, obviously their
Yeah.
family doc's going to refer them to you. Do
Yeah.
they get referred specifically to you or to the Create Fertility Center, or how does that work? And then what kind of protocol or steps do you take in the initial phases?
Yeah. So, I mean, much like most other clinics, and you can either self-refer or get a referral from a family doctor. If you're an out-of-province patient, it's obviously different. You don't need a referral. You can be referred either to the clinic, and we have multiple doctors, or certainly it's great if you're referred to a specific doctor like myself.
Sure.
We're still doing virtual consultations as a first step, and I think patients really like that because they can do the consult from the comfort of their own home or when they're
Yeah.
on break from work. So it's kind of stuck in our clinic. And it works beautifully. You don't have patients upset sitting in the waiting room if they're delayed by 20 minutes. I'm a bit of a stickler for time, so I try to be on time, but you know how things go. So we start out with a virtual consultation where, I spend 40 minutes to an hour getting the patient's complete history, any sort of previous diagnostics, previous treatment cycles, what their outcomes were. It's always great if I have the records for review. And then if we want to update any testing, we'll sort of discuss that and what my initial thought process is as to what I think their treatment plan should be. Now, obviously, for a new patient who's coming in fresh and hasn't done any diagnostics, it's a lot of sort of positive predictive value based on what I think the testing will look like. So, for example, a young patient under 35 who appears to have no major history, what I usually tell a patient, because I kind of like to plant the seed of what my thought process is looking like, is I say, look, you're young, healthy. If everything looks good, we can consider doing fertility medication and IUI for a couple of cycles before moving on to IVF. Obviously, that treatment plan is going to be different for someone with diminished reserve who's older, who's starting later on in life, maybe has had previous diagnostics that show a reduced ovarian reserve, maybe a male factor. That's where we start talking about best practice IVF protocols as initial treatment.
Right.
And so what I do personally in my practice is after I see the patient, talk to them, I send them an email personally with my team CC'd, and I review everything we talked about and what the diagnostics are going to look like. We set up the diagnostics through our assistants, and then we either will do a follow-up, or for some patients, like the second and third opinions who are up to date and they just want to get right into the IVF process, we bring them in quickly because we know time is of the essence. So
Right.
if a patient wants to start IVF like in a week with her next period and she's up to date with her testing, we can absolutely do that and get them in. It's different with, third-party reproduction where patients need to find an egg donor and surrogate. Those are a little bit more complex, but usually I would say from the time that a patient sees me for consultation till they get to treatment, we're pretty quick with getting the diagnostics done and moving forward with treatment, again, because we understand time is important, and patients who come to the clinic are interested in getting pregnant yesterday for the most part. And if they're freezing eggs, they want to freeze eggs tomorrow. So we
Right.
really want the process to start and be smooth as soon as possible, if that answers your question.
Yeah, that's awesome. I'm curious about your egg freezing. So,
Yeah.
what are you telling like the different age categories of women who are
Yeah.
listening to this show in terms of, either how many eggs they'll need or what rough number of cycles you anticipate they'll require? So maybe like under 35, 35 to 40, over
Yeah.
40. What are you coaching those patients
Yeah.
with?
I mean, obviously, this is based on their ovarian reserve testing
Yeah.
because, as we all know, a 37-year-old could have a high AMH and a 33-year-old could have a low AMH. But typically, I go by Ana Cobo's data, from Spain, who published some of the sentinel studies. And usually I say for a woman under 36, if you have 15 to 20 eggs, that you have a 60% chance of having at least one baby.
Right.
So that's sort of my target. And for women over 36, again, without their ovarian reserve parameters, or even if they have normal ovarian reserve parameters, I kind of plant the seed saying it's possible you'll need more than one cycle to
Right.
get up to that 20 eggs. Just because we know age is king, right?
Yeah.
If you're older, even if you have normal reserve, you might not make as many oocytes with a single cycle.
Do you guys have like batched cycles kind of where you offer them a package for like 2 egg retrievals or 3 egg retrievals or something like that?
Yeah. I mean, certainly what I tell patients who I think will need more than one cycle, and from experience, I think we both know which patients will need more than one cycle,
Yeah.
whether it be for
For
FERPRES,
sure.
whether it's for FERPRES or for IVF and PGTA genetic testing. You kind of know those patients that are going to need to batch over multiple cycles. And so, yes, we do have discounted packages. Some of it is sort of individualized. Like if the patient's been with you for a while, we have our standard package is like 3 cycles for the price of 2, where they buy 2 and they get 1 free,
Right.
aside from the PGS and the meds. But yes, in answer to your question, there are batching programs for patients where they do save some money, because it's very common these days for patients to batch. And sometimes it's just not even because they have low reserve, but because they want multiple embryos at a young age so that they can
Yeah.
have children later on without a problem.
Yep. Absolutely.
Did you see that recent article about a couple who came back 30 years later to
Yes.
transfer an embryo?
I just got that
I
today,
didn't
actually.
post
Yeah.
that one
Yeah.
because I was like, if you add 30 to 20, then imagine how old the patient was. But
Yeah. Yeah. And I think they ended up having twins, right? Something like that.
I don't remember the outcome.
Yeah.
But
Yeah. I
saw
saw
the
an
headline.
article today that said twins after 30 years. I was like, wow,
Yeah.
that's a long
I
time
mean, you
to
have to
frozen
imagine the
embryos.
patient's 50 at least, though.
Yeah.
Right?
Yeah.
You would
yeah.
imagine.
Crazy. Crazy. Well, I think we probably have a ton of questions for you,
I
right?
see
Yeah,
that,
Tarek
yeah.
is itching to start asking questions, so fire away, T. And I have to warn you that Tarek uses this show to stoke his own ego because he always picks the questions where they've referred to him as well. So, so he'll ask the
Sure.
questions and feel free to take a crack, or if you want me to, no problem.
Sure, we can
There,
have a
there was
discussion.
one
For
question
sure.
that really caught my attention.
Okay.
I dare
Oh, I dare. Uh-oh.
Dr. T to answer this.
Oh, okay.
I don't know if I should. I'm not sure if I should. What is the greater predictor of gestational diabetes? Weight pre-pregnancy or weight gain during pregnancy? I have PCOS and I'm on metformin during pregnancy.
Oh, Pratty, do you still practice any obstetrics?
I
Do you want
mean,
to take
no,
a
I
crack
mean,
at that?
I think your pre-pregnancy weight definitely plays, like there's definitely data to support that your pre-pregnancy weight is going to be a predictor for pregnancy outcome. I think we all know that BMI can predict the risk of pregnancy complications, and gestational diabetes is certainly one of those complications. Weight gain during pregnancy, I don't know how much data there is. I mean, maybe you can help me here too, because it varies, right? Like we have those typical amounts that we say, like 25 pounds is average for a normal BMI patient, less for someone who's obese or overweight, and more for someone who's underweight. But I'm not sure if there's a predictive nomogram based on how much weight you gain in pregnancy. Certainly, if you gain more than the required amount, I can imagine your risk is higher because fat produces insulin. But I'm pretty sure your pre-pregnancy weight is going to be a determinant for.
Yeah, so I mean, I guess for that person, I totally echo everything you're saying.
So do I.
So
There's just two doctors in the room. I felt it's inappropriate to weigh
to weigh in, yeah, thanks for that. Tarek's gotten like a minor medical degree listening to
sounds
everything
like
that
it,
I say
sounds
on
like
this
it.
show. So yeah, I mean, pre-pregnancy weight is definitely critical. There's no question. And pregnancy weight gain, there are studies that have shown that the amount of weight you gain in the pregnancy is predictive for sure, as you mentioned earlier. So I think they're both important. I'm not aware of any studies that have done a head-to-head comparison to say whether your pre-pregnancy weight gain is more predictive than your in-pregnancy weight gain. But actually, for that individual, the strongest predictor is the fact that you have PCOS. So if you have PCOS, your risk of developing gestational diabetes is going to be very substantial, especially if weight is part of your PCOS diagnosis. So if you're a normal PCO, you're not in that thin PCO category, your risk of developing diabetes over the course of your lifetime is about 50%. And if you're getting it during pregnancy, it's certainly a possibility as well. So I don't know of any head-to-head data for which one is more predictive, so it's a great question. But I think both of those issues are going to be critical, your pre-pregnancy weight and then what you gain during the pregnancy. They're both
And all
going
the
to be
more
important.
reason to check an early hemoglobin A1C in the first trimester. On all my PCOs, I check it early.
Yeah.
Because if you find it earlier, it's going to be more important, obviously, to get good glycemic control.
Yeah, yeah, and glycemic control is huge for all those patients pre-pregnancy and certainly in the pregnancy as well, for sure.
There's a lot of questions.
There's a lot of questions.
Disclaimer.
Okay, there you go. We're gonna have to have Pratty on the
ready.
show more often. Fire away.
We'll do an all-nighter.
There'd probably still be questions all the way till morning.
Although
Pratty.
I was up at 4 a.m. doing my ABOG article, so I'm
Oh,
not
boy,
sure to pull
that's
an
early.
all-nighter
Wow.
with you tonight.
Okay, hi, Dr. V. Omnitrope for egg quality before stims and how much and when?
Good question.
Yeah, Pratty, do you use it?
So I think every REI on this planet would say they use it, even though the evidence does not necessarily support it. And I feel like every month I see a different article saying it's fallen out of favor, maybe it works, it might or it might not. So, I do use it. If you go back to basic reproductive endocrinology 101, like what does growth hormone do, right? Growth hormone increases, it basically creates a PCOS-like environment because it increases
Right.
insulin and IGF, right?
Right.
And there are insulin receptors and IGF receptors in the ovary. So the idea is you're doing exactly that. You're increasing growth hormones to increase steroidogenesis and create this PCOS environment. So I think going back to the science, I do believe in it. I don't know that the Cochrane database or any RCTs have proven benefit. I have seen some newer data, and you probably saw this too, like Eshrey actually published it, that maybe one of the effects of growth hormone during stimulation is actually on the endometrium, and
Right.
even more so maybe than on egg quality. So I thought that was interesting too.
Yeah. So we use 8 units a day. There's no standardized protocol for this. I started about 2 weeks prior to stim. And as far as the data, initially I started using it, then a study came out saying it wasn't useful, so I kind of stopped for a while. And then there was a meta-analysis last year, I think we reviewed on the show. I think it was last year. So that meta-analysis said there was a benefit. So the benefits were higher egg count, more high-quality blastocysts, and more mature like M2 oocytes. So they did not show an increase in live birth, which is obviously our holy grail, but they did show that there were benefits in the rest of it. And I said, if it's good enough to get me more mature eggs, and more fertilized, good quality blastocysts, there's got to ultimately be some chance that that's going to benefit the patient. So I always tell the patients, look, if you've got coverage or you can afford it, it's certainly not going to be harmful. It'll probably be beneficial, but we don't have live birth data yet to support it. So yeah, we do use it, and I do like it in my poor responders quite a bit.
And how did you decide on your dosing, your protocol?
So we
Is that
just
based on
used
the
that 8
study?
units because that was the most common one that I saw in the literature. Some people are using 6, some people are using
And you're
8.
using
What do
daily,
you do?
huh? Not every other day?
We do it every day.
Yeah. It's expensive for every day. I mean, I'm not sure. I don't know that there's been studies looking at daily versus every other day.
Yeah.
I haven't seen any. The pre-treatment, yes, I've seen lots of data on that. But with patients doing back-to-back cycles, it's,
Oh, that would
like
add
they're-
up for sure. Yeah.
or if
yeah.
they're stimming, like they're kind of constantly on it, right? So if they're doing back-to-backs and duos and things like that. So yes, I mean, we use it, and we use it every other day. Sometimes I'll give it pre-stim. Sometimes they get it anyway if they were in a duo before. So
Right.
yeah.
Right. Cool.
I
And
started
what
someone on
dose
it
are you
today.
guys using?
So we're using, I mean, I think it's like equivalent. It's probably the 3.33 IU, or is that 3.33 milligrams every other day? Ours is a milligram dosing. I think it
Yeah.
is the 8, and it's every other day.
Yeah, I think that actually does add up to close
Yeah.
to 8. So
Yeah.
that's probably right. Yeah.
We
same
don't,
thing
I
as
mean,
us.
some patients do every day because they request it. So I think that protocol has been circulated and patients ask for it, and we do consider it.
Cool. Next question.
Hi, Team TV.
Yeah.
What are the chances of a hydrosalpinx after previous right hemocolonectomy
Hemicolon.
Hemicolectomy.
Yeah.
and infection from Crohn's disease? 3 failed embryo transfers. Doctor wants to do laparoscopy. Thanks.
Good luck to
Whoa.
the doctor doing a laparoscopy after a hemicolectomy. That's some surgeon.
For Crohn's, yeah. Wow. Yeah, I'm gonna agree. This is why I love Pratty. So, listen, if you're going for surgery for a hydrosalpinx after a hemicolectomy, your risk of injury would be extremely high in my mind. So, especially laparoscopic, I would be very careful and cautious in a scenario in which anybody could endure or encounter an injury from any kind of surgery. So I'd be super careful about that. Pratty, I don't know if you had any experience with that hysteroscopic coil. What's that thing called?
Yeah, we used to do those all the time. We did them
we used
all
to
the
do it in
time.
the States. You guys aren't doing it at
We did them
Create,
at
are you?
Create. I mean, not recently. We did them. I had great experiences with it because, again, this would be the perfect patient if you were worried about a hydro and
Yeah.
they're committed to IVF, right? Like
Right.
you're not concerned about the tubes. And I have put them into patients like these, and they've done beautifully, right? Because the tubes are not an issue. They're not going to get pregnant through the tubes, but obviously it's fallen out of favor. I mean,
Right.
in speaking about hydros, and I welcome your comments as well, like hydros are such an interesting thing, especially in these patients who've had previous surgery, right? Because it's like, is it a hydro? Is it a peritoneal inclusion cyst?
Right.
Like, are we really going to screw up the implantation rate? But again, I think this is where individualized care comes up. Like, do we really want to scope a patient who's had multiple abdominal surgeries? Or if they've created multiple embryos, they still could potentially get pregnant. So maybe you try a transfer. If it doesn't work because it's a unilateral potential hydro, then you consider, surgical intervention with someone who's a specialized surgeon because of the risks, right? It's tricky. Maybe MRI could help you diagnose if it's a hydro or not. Like, it's different if it's a primate belly to go in and remove a hydro, right?
Yeah, I mean, I in a situation like this, I would not be keen to, even refer that patient. I mean, I'm still doing a ton of minimally invasive surgery, and I would be very reluctant to even refer that to an expert, because that's going to be a super high chance of somebody getting injured. So yeah, I'd look for every opportunity to avoid that. Certainly, we both know that there's a significant impact of a genuine hydro on IVF outcomes, but would I dive into that one without at least, trying everything else first? No, I would
And
be
honestly,
reluctant.
I've had patients conceive while they're waiting for their laparoscopy for removal of a hydro, right? Because if you look at the data, the 50% reduction in implantation
Yeah.
was like, it has to be an obvious hydro, not a questionable hydro,
Right,
right? And
right.
so, and typically bilateral more than unilateral. So, not saying that you should just leave hydros in, but in these complex surgical patients, as you said, it's important to look at the full picture.
For sure. All right, great.
Got a big one.
We got a big one. Uh-oh. All right.
Hi, everyone.
Okay.
Everyone's
Starts with high.
Yeah. I'm very happy to see another reproductive endocrinologist in the show.
Excellent.
I have a couple of endocrine questions.
Okay.
One.
Okay.
There's a bunch of them. So
Oh, jeez.
you gotta
Rapid fire. All right.
Get ready.
All right, I'll write it down. Go for it.
Okay.
All
One.
right.
Would you like some details on when it makes sense to try medication in male factor infertility? What assay results prior to medication would you like to see? What initial FSH, LH, and testosterone levels? Is it reasonable to try, for example, Clomid if T is 11 nanomoles per liter, around 350 nanograms per ml, FSH 4.4, LH 3.3 IU over L.
Okay.
I have prolactomania,
Prolactinoma.
prolactinoma, and all the meds for IVF have it as a contraindication. Should I be afraid of doing IVF? Prolactin is now normal. 3. There seems to be a lot of confusion about the criteria to diagnose IR in Europe. Everyone uses OGTT with insulin and glucose measurements, but there seems to be a lot of inconsistencies in the interpretation of these. How do you define it?
Wow.
That's a lot.
I'm going to leave the two super tough questions for Pratty. No, I'm kidding. Pratty, when do you give your guys hormone therapy? Like, which category of guys would you say, hey, take some Clomid or HCG or even FSH?
I mean, I'm not going to claim to be a urologist for sure, and we're lucky to have really great allied partners in, urology and fertility to help us.
Yeah.
But certainly you're right that when a couple comes to us or a male comes to us, that we're like the first line. You get their semen analysis and you see what's going on, and maybe they want to try IUI, they can't get into the urologist. So I think if their gonadotropins are normal, like their FSH and LH, and it's a mild male factor, and I should go back to the FSH and LH, like I just remember from my fellowship as well that you can't use the same FSH and LH parameters that you use in women for men, because even a slightly elevated FSH or LH in what looks like might be normal for a woman is actually elevated for a male. So
Right.
you have to be careful there. But I think with like fairly normal FSH and LH levels and borderline low or normal testosterone levels and a mild male factor, meaning the counts are a little bit borderline, like instead of 15 to 20 million per ml is the concentration, it's like, 13 or something, or 12 with normal or good motility and good morphology. and maybe the IUI counts are just a little lower than you'd like, I think it's reasonable to try Clomid. So yes, I will put my guys with mild male factor and normal hormone levels on Clomid if they just want to try something. The hypo patients who are, let's say on testosterone and they get off testosterone or steroids and you want to jumpstart their sperm production because they're hypo, absolutely, they need FSH and HCG. Have I started those guys on it? Maybe in the past a little bit, but usually I'll defer that to our urologic colleagues to determine dosing. But I think we can kind of figure out who needs gonadotropin therapy to jumpstart sperm production.
Yeah, I mean, I would echo the same. Like for the guys, if they have a low FSH, LH level and a low sperm count, I will use the meds for them. I typically find that HCG works better than the Clomid does. Unfortunately, I don't have the luxury of having a urologist out here, so I end up doing a lot of that stuff on my own because we're in a much smaller community. But I do use it for kind of the same group of people. And of course, if there's very, very low sperm counts, then I'm always also asking, is there something else going on? So I'll explore the other possibilities. But we definitely kind of look at the whole picture and then decide. I very rarely use FSH. It is in the ASRM guidelines for treatment of male factor, but I think I've probably done that once or twice in the last 15 years. Usually if Clomid and HCG don't work, I'm actually sending them to one of the people you're working with in Toronto also for them to take over management, because I think it's starting to get past the realm of where I would usually be involved. Okay, so the second question was prolactinoma. Are you stopping your patients with a prolactinoma?
No, God, no. That's outrageous. Like, I mean, I think normalizing prolactin is important, but I'll go a step further and say that for those patients who have a prolactin under 50, when you're stimulating them, the medical endocrinologists actually don't get too fussed about prolactin levels unless they're well over 50. But yes, we do treat, obviously, and stop once they're pregnant, but absolutely not. It's not a contraindication to gonadotropin therapy.
Yeah. And then insulin resistance. I mean, we were talking about that earlier. We use fasting glucose. We do a fasting insulin. We do an A1C. I mean, I'm taking my measures based on that, but I'm not sure about why there'd be controversy. I think most countries have their own established guidelines. We have ours in Canada. They have them in the U.S. Endocrine
I think the
Society
OGTT is, the gold standard, but that's a very cumbersome test.
Yeah.
And so I think in our population, either they're diabetic because their family doctor has picked it up, or you'll pick it up with the hemoglobin A1C.
Right.
And, if their hemoglobin A1C is borderline, they're probably IGT. So I don't think you really need the OGTT.
No, I agree completely. Okay, next question.
Bonsoir, my favorite duo from Quebec.
Oh, very nice. Hello from Quebec. Cool.
In a modified natural cycle, FET, do you recommend adding vaginal or both PIO and vaginal suppositories? How much should the dosage be for each? Thank you.
Pratty, what are you guys doing in a modified natural?
Yeah, I mean, I was just at ASRM, and most of the talks on modified naturals or natural FETs said there is a benefit to giving a little bit of progesterone. Although, if you think of in a woman who has regular cycles, you probably don't absolutely need it. But what we're doing, whether it's a letrozole FET or a natural FET, I mean, I tend to give BID vaginal progesterone. Some patients just have a preference for progesterone and oil, and that's fine. They can do it, but I think vaginal is completely sufficient for natural or modified. That's obviously not to be compared with the artificial cycle where you take estrogen and progesterone. In those cycles, I think the pendulum is swinging towards favoring PIO.
Yeah, so we do both always, even in our letrozole or our natural cycles. The main reason we do is there was a comparison study mid-year last year which showed that the combo was best, PIO was second best, and then vaginal was third.
In natural or modified natural? Because that's not what ASRM
So that's the thing. The study actually included everybody.
Yeah.
So they didn't break it down. And the one thing we do find is we do need to titrate our doses a lot more carefully for those naturals and the letrozoles, because if they do spring an egg, especially with the natural cycles, which they will, they're going to start adding their own corpus luteal progesterone, and you can overshoot. And then I always tell my patients, like, you can, at least in my philosophy, you can overshoot the proj. I think if you get too high, you'll get endometrial asynchrony, and you'll run into trouble. So we usually use both, but I'm extra careful with the amount that I'm giving them when it's a natural. So it's interesting to see, a different perspective for sure.
Yeah, I mean, I know places that do 0 progesterone with natural and modified naturals.
Yeah.
So
Yeah. Well,
I think
we've
it's
had
helpful.
some where their progesterone level is sky high because, they took letrozole and they released 2 eggs, and
Yeah,
now all of a sudden
exactly.
they've got a high proj, and then you can really overshoot. So great question. Yeah.
If you could have frozen sperm from a 25-year-old donor or fresh sperm from a 45-year-old, which would give better results?
This is like, would you ever? Never have I ever. I have heard this question before.
So what would you do?
I mean, I would probably say that take the frozen sperm from a healthy 25-year-old, because there's lots of data coming out about advanced paternal age.
Yeah.
And not only risks of male factor infertility or sperm defects, but long-term outcomes, including mental health issues, autism, things like that.
Yeah.
We know that older sperm has higher DNA fragmentation index, which is associated with implantation failure and miscarriage. So yeah, that would be my take. How about yourself?
You know what? I would have literally said every single word you just said. So yeah, we
Great minds
actually
think
have a
alike.
video on it on our YouTube channel where we talk about the impact of men's age on sperm quality. So I think a 25-year-old healthy frozen sperm sample would likely end up yielding a better result than a fresh 45-year-old. Now, of course, it depends on the parameters of the sperm, and I'm sure you've seen where you buy donor sperm from a sperm bank and it arrives and the guy could be 25, but
Yeah,
what they
crap,
said it was
yeah.
like and what it actually is
Totally.
like can be totally different things. But yeah, I would think, apples to oranges here. If you have good 25-year-old sperm and you've got good 45-year-old sperm and the 45-year-old's fresh and the other one's frozen, I'd still go with the 25-year-old, exactly for all the reasons you mentioned. Autism's higher, DNA fragmentation's higher, risks of anomalies and stuff is higher. So I would also favor using the younger guy's sperm. That was a really good question. We've never had that question before. Very cool. Prati, I need to be cognizant of the time because I know you have little ones. We want to continue this for sure, but let me know when you've got to go because we don't want to keep you any longer than you need
We
to.
can do a few more minutes. for
Okay,
sure.
perfect. Great.
She likes the show.
She likes the show.
Oh, I'm roped in now.
That's right. Yeah.
Yo, T.
Yo, T. All
And
right.
my favorite Dr. V.
Aw.
Hi. Recently had 3 betas at 8, 10, 12
Okay.
days after 5-day transfer.
Okay.
Levels at 65, 165, 300. Is this good? I am 40, had previous miscarriage. How much more would you continue to test?
So first of all, we don't test on day 8, 10, 12. We just wait till day 14. I know not everybody does the same thing, but we try and keep our patients that long just to make sure we're getting a reliable result. And then we'll check usually just once more. And if it's doubling as yours is, you should feel comfortable. Super early on, the beta does not double initially. It takes a little bit for it to get to the doubling phase. So we don't really follow that super early. We just wait a little bit. But Prati, at what point are you guys
I mean,
doing
I
it?
think it's a delicate balance, like frequency of HCG levels and,
Yeah.
Stress for the patient and, even stress for the doctor to wonder what's going on. I follow Kurt Barnhart's data and he's like the guru of the beta HCG curves. And he basically hit in the 80s, or not in the 80s, sorry, the 90s kind of redefined the HCG curve, saying that it's not a doubling pattern, but it should go up by 2/3, so 66%, right?
Yeah.
So when patients get worried about that, I'm always like, really, you only need 66% in 2 days, which is doubling in 3 days. So you can space it out a little bit.
Yeah.
So yes, we check post-blast FET, we do 12 days.
Yeah.
And usually like for our surrogates, we do 2. And for regular patients, it's 3. And then, as long as those look appropriate, then we just do their viability scan at 6 to 7 weeks.
Yeah, we're using a 60% minimum rise, same thing. And yeah, I'm doing the same thing. I'll do like 2, and then if it looks good, I'm going to the viability scan. And we do tend to do those early to alleviate the patient's concern, but I certainly wouldn't be encouraging someone to do 8, 10, 12, and then more. We would say like, you look good now. That's enough. Like wait until your viability scan.
That being said, I think we're in this great time of like very sensitive ultrasound scan. So if you're worried about the betas not rising appropriately, we're able to detect ectopic pregnancies at an early phase,
Right.
which is awesome because we can treat them medically.
Yep, for sure. Absolutely.
Hi, Dr. Sharma.
Oh, hey,
Hi.
there you
Wow.
go.
I am a Create patient living in Windsor.
Oh,
Oh,
I saw this question.
The long
And
commute
why
to
aren't you
Toronto-
going to Dr. Victory is the question.
The long commute to Toronto is hard. Has the clinic considered allowing monitoring at VRC? If not, can that please be a consideration?
oh, I guess they're asking maybe about IVF funding, Pratty. So I don't think we have an arrangement with you guys to do
Oh, for funded cycles.
funded cycle monitoring.
Well, I wasn't even thinking about the funding. I think it's just unless you're a satellite of the clinic, your original clinic, you have to pay a fee, right? So you could satellite anyone, but there would be a fee.
Yeah, I mean, all of
unless
us,
it's a
like we
funded
use
cycle.
Create
Yeah.
sometimes for
Yeah,
satellite
for
monitoring.
sure.
Yeah, when it's
But
going the other
funding
way.
is different because it's a bucket, right? So that gets
Yeah.
complicated.
Yeah. So I think that's something that you could take back to Create, certainly. But I mean, we'd be happy to monitor anybody wants us to.
Right. So I
and-
would say to that patient in particular, and sorry, not to interrupt, I think, these things are case by case basis too, right? I mean, I can speak for myself that in the end, I want this to be a stress-free process. So
Right.
like if I had this exact patient and you were my patient, I would pick up the phone and call Rahi and say, hey, listen, do you think, we can work something out?
Yeah. I'd probably do it for another dinner with Pratty because I love her company. So it would be pretty easy to work something out. Absolutely. Just contact, Dr. Sharma, and I'm sure we can figure something out that'll help you for sure.
T, one more question.
Okay.
Dr. V, thoughts on taking probiotics during pregnancy? Any other vitamins aside from prenatal? What about melatonin?
During pregnancy, interesting.
So I'm a big believer in melatonin. There's lots of data for pre-IVF and then for FET for a significant improvement in outcomes. So we use it all the time. Other vitamins, vitamin D, fish oils, your prenatal vitamin, obviously, CoQ10 if you're going into your stim. And then we kind of tailor the rest of them depending on what your conditions are. So for patients with PCOS and patients with endo, we have a whole protocol of supplements that we use for them. Pratty, what do you guys normally do?
Yeah, I don't think our vitamin supplementation plan is as extensive as yours, it sounds like. So I'd love to, hear more about that at some point offline. I mean, I agree with you that things like melatonin, CoQ10, maybe DHEA and vitamin D are quite important sort of pre-IVF. I'm not as familiar with the melatonin data, so that's cool. And for PCOS, I think inositol is really great. I mean, the head-to-head studies of metformin versus inositol are pretty impressive, I would say.
Yeah.
So I think inositol is a great supplement for PCOS, but I think just lifestyle management in general is super important for PCOS patients, in parallel with their ovulation induction or fertility treatment. I think, I haven't read it from cover to cover, but because so many patients talk about it, but it starts with the egg book, like I've kind of perused it. And I really think some of the supplements recommended in that are kind of like they have evidence to support being on that cocktail. For male factor, even though maybe the data doesn't really support it, I'm a believer in, the antioxidant cocktails in Fertile Pro and things like that for male factor infertility.
Yeah,
I think they
yeah,
do
me
make
too.
a difference.
Yep. Yeah, I agree completely. Yeah, we can definitely talk about what we use. We actually have kind of built into our order set for endo patients and PCOS
Cool.
patients as to what supplements we use. I work fairly closely with our naturopath who's on site, and I think it improves the patient experience, and we believe it's helping with the egg quality. We actually just started doing IV vitamin therapy here too.
Oh.
Yeah, so I think some of that stuff is really going to help patients. It's not going to help everybody, but it's going to help some patients who are deficient or are chronically exposed to stuff that, has high oxidation levels. So I think there can
Yeah,
be a
that's
benefit.
fair.
Yeah, for sure.
35.
Okay,
4 failed IUIs.
okay.
I got pregnant naturally, miscarriages at 12 and 5 weeks.
Oh, sorry.
All our test results came out normal. Should I start taking low dose aspirin? And should I try IVF?
Dr. Sharma?
So I want to make sure I got this correct. 35-year-old, 4 failed IUIs, 1 natural miscarriage.
Two natural miscarriages,
natural
it sounds like.
miscarriages.
Yeah.
Yeah, I mean, technically, I would say, before moving on to IVF, that you would warrant a recurrent miscarriage workup if there were
Yeah.
unexplained miscarriages, just to make sure we're not missing anything like a translocation or a thrombophilia or hypothyroidism, something outside of the box that we haven't picked up otherwise. But otherwise, I think just based on pure fertility treatment, I think being 35 and sort of qualifying as advanced reproductive age, and the fact that we know that 99% of miscarriages are due to chromosomal aberrations or genetic aneuploidy, and you've tried the conservative route with 4 IUIs, which is a very reasonable, good shot at IUIs. I think, it's not that it's an absolute to move on to IVF, but in terms of time to conception and likelihood of achieving a viable, healthy pregnancy that's euploid, IVF does make sense at this point, especially if you want more than 1 child.
Yeah, I would agree with all of that. I think we would definitely encourage them to do investigations for recurrent implantation failure or recurrent pregnancy loss. And we would want to explore all of the possible sources and causes of that before we decided what other therapy they might need. The short answer to their very good question, would I use aspirin? We use aspirin for everybody. So for me,
Yeah,
that's a
right,
no-brainer.
Yeah,
But the long answer, I think what you said, we would do the exact same thing. Yeah, which is why you and I get along so well. Do you have time? Do you still have
And
time?
then we'll do one more,
One
more,
more.
and then
All right,
I do
perfect.
have to sign off.
You and I are going to be here
Hey,
till like
Dr. V
9:30.
and Dr. Sharma.
Okay,
This is for the both of you.
for the two of us. All right.
Tag team.
Curious to get both your opinions.
Okay.
I feel controversy is brewing here. I'm 29
Okay.
with diminished ovarian reserve.
Okay.
If I were to freeze embryos and or eggs, would I be drastically decreasing my chances of conceiving naturally? And if
Can I hit the
so-
buzzer on this one? No, I'm just kidding.
And if so, what would be my options? Bang. That's right.
And what would be my what?
My options.
Oh.
What would be my best options if I were to conceive naturally?
No, I mean, I was half joking to say that because I think that women, particularly young women, get very hung up on their low AMH if they have one. But actually, if you look at all the studies, the predictive value for euploid embryos with IVF and even natural conception are actually quite good and almost age matched. So just because you make less embryos or you have less eggs that result from IVF at a young age because you have a lower AMH, it doesn't mean that your outcomes are lower. So you might create 1 euploid embryo as opposed to 5 euploid embryos in 1 cycle, but your ultimate pregnancy outcomes are probably still the same. It might take longer to batch your embryos together to have multiple children, but age is king or age is queen, I always say. So your young age should hopefully take you far.
Yeah, there's I'll admit I'm still confused on that one because I've seen studies that go both ways. So about a year ago, I saw a study that said that if you have DOR and you're young, you have a higher risk of aneuploidy. And then I saw another one right after it that said, no, it's the same as the age-matched control. So I think not clear on that yet as far as the overall message, but I definitely would not tell this patient that she needs to worry about her own fertility if she does egg freezing or embryo freezing now. The number of eggs you're going to yield per cycle with diminished ovarian reserve is going to be relatively modest, and you still, even if you're approaching menopause, we know that there are still a lot of eggs left in the ovary. So I would not be worried about doing egg freezing or even doing embryo freezing if your ovaries are strong enough.
And I think the data does show if you're not an infertility patient and your AMH is low, then that is not as predictive as if you actually have true infertility. So if someone's coming for fertility preservation with a lowish AMH, I've seen many of those patients conceive naturally afterwards. That being said, we still use that as a guide to predict our dosing and eventual outcomes.
Well, listen, I cannot thank you enough. I think based on the massive number of people watching the show and asking questions, we will have you back shortly. So thank you so much for joining us. I think Tarek and I are going to continue answering.
Yeah, you guys go ahead, enjoy, and I look forward to the next session. And have a good night, everybody.
It was awesome having you on. Thank you so much. Just tell us before you leave, if someone wants to come and see you at Create, how should they get a hold of you or your office?
Yes. So my assistant's name is Jasmine, Jasmin, and you can email her at jasmine@createivf.com. Say you saw me on the show and you're interested in seeing me. She'll kind of get you ahead of the wait list. I'm also on Instagram at drprati, Prati, A Sharma. So feel free to message me. I love when patients ask questions or comment on a post. So please reach out and I can reach out to you and say how to connect in Toronto. So I'm pretty accessible that way. Thanks
awesome.
again, Rahi.
Thank you so much. My apologies to Jasmine. Jasmine, you are going to be inundated with calls and emails shortly.
I really, truly hope so.
Yeah.
So I'm going to click the leave button. I don't want that to mess up your feed.
No, you're good. You can leave. Have a great night. I hope your little one feels better, and we will see you again on Fertility Factor Fiction soon. Thanks, Prati. Take care. Have a great night.
Bye.
Wow, that was awesome. She was amazing. Yeah. I hope you guys enjoyed that. If you want Prati back on, show us some love. Let us know. Lots of likes and thumbs up and whatever app you're using, whatever the positive sign is there. I'm assuming there's like a gajillion questions. Yeah, Tarek's making very funny googly eyes at me off camera here. So I can rapid fire through some. Like we're almost. Is it impossible?
Rapid fire is a strong word.
Well, let's pick some good ones.
I'll give you the phone.
Oh, you want me to just go through the?
I think sometimes you go really fast when you do it that way.
Okay, Tarek's phone. Oh God, this is going to be a nightmare. Ovaries are high and not visible transvag. Is there other retrieval options? Yes, it's called the transabdominal retrieval. So you take the ultrasound probe, you put it on the patient's belly, you still use the same vaginal probe but on the abdomen, and you just go through there. So that's actually very easy to do if you're good at it. If you are not good at it, for the love of God, don't ever try doing that because you could really massively and life-threateningly injure someone if you pierce the bowel or a major blood vessel or whatever. You logged off for me there, pal. I'll have to keep my finger on it. Okay. How long is the wait list for a funded round at your clinic? Probably about 8 months, I think, right now, somewhere in that vicinity. What's the impact of smoking marijuana on egg and sperm quality? So for egg quality, it severely diminishes your egg quality. It's a 250% increase in miscarriage rate, and it has very significant negative impact on the chances of fertilization, of blastulation, and of implantation, and of live birth. For a guy, it's a train wreck disaster. Again, it very significantly increases the risks of miscarriage. And there are actually fetal effects if you continue using marijuana through the pregnancy. So we don't ever allow any of our patients to use marijuana. We actually blood test people for it, and if they test positive, we stop. We do have a great video on YouTube on marijuana, although I watched it the other day and it's in the Instagram format, so you can't see anything. We got to redo it and put it up on a YouTube format. So remind me and we'll do that because I still have the presentation. Is IUI possible with 1% motility and 19% DNA frag or IVF better? Yeah, IUI is not possible if you have 1% motility. You'd have to have 300 million sperm per milliliter for that to even be meaningful at all. So no, it's not possible. Don't even think about that one. Hey to my favorite duo. Hey, yeah, that's us. What is the max estrogen level for medicated FET? Thanks. There isn't one. So there is no max level of estrogen. We have some that have really high levels because they needed to get their estrogen level up high enough, and other ones have really low levels. So you don't need to worry about a max level, not really critical. What is causing PGT to come back as abnormal, and what can be done to improve quality? Either the sperm is genetically abnormal, or the egg is genetically abnormal, or when the two of them got together, it wasn't a great combo, and the genetic part of things just didn't work out properly. So can you improve it? No. Although there are some things we think. So number one, the ratio of recombinant gonadotropins like Gonal-F, Recavel, all of the ones that are out there, to urinary, which is now just Menopur, should be 50-50 to optimize your euploid rate. The other thing that we've just started playing with is that there is a study which I pulled out the other day. It's back here. I'll probably go out of focus here. This one right here. And this study says that if you delay the time to retrieval, you actually get more euploid embryos. They waited as long as 39 hours, which is kind of terrifying for me, but we've extended to 37 for now. We're going to see how it goes, and I might nudge it forward half an hour at a time till we start seeing people pop off their eggs, because the longer you wait, the more they might release, so worrisome. How many implantation failures constitutes recurrent implantation failure? I think that's center specific. There's a lot of debate on this. There is no accepted agreement on a number. In our center, depending on if it's donor or autologous, we would say 1 or 2. We're really strict about that. Most places would use 3. I have a hard time ethically justifying 3 because that's a lot of embryos and potentially a number of IVF cycles. So we're going with 1 for our donor population and 2 for our autologous. Hi, Dr. T and V with a tongue stuck out at you. So I don't know what that means, but whatever. Please, can you explain the differences in the modified Lucinda Veek and Gardner systems?
There you go, Lucinda Veek. I'm glad I didn't have that one.
I am not even familiar with the Lucinda Veek and Gardner systems. If you're referring to embryology scoring systems, I would need to pull in my embryologist. I'm gonna have to look that up. Can you show me that one, and we'll check that one out later? Yeah. I think I answered all your questions.
Oh, you did wonderful.
I did. See, I did the rapid fire.
I knew you could do it.
But you started me low. Do you want me to go backwards? Oh God, there are like 5 million questions here. Okay, hang on. Let me go backwards. Hello, T and V. Is it okay to take supplements during stim injections? Yes. HGH before or during stims for egg quality? Both, before and during. What dosage? 8 units. How long? 2 weeks. Although Dr. Sharma said she does it at a slightly lower dose, I think, and she also mentioned that they do it every other day, which is great. What could cause day 21 ovulation spotting 9 days later until period around 11 days? Implantation or an abnormal lining or a fibroid or a polyp or low progesterone. Do you ovulate during a programmed medicated FET cycle? Not during a programmed, no, you shouldn't. I mean, you could, but you shouldn't. Why do you need both forms of progesterone for successful? Because there's a study that shows that it's better. So there's a study that we reviewed on our show. It's on our YouTube channel. Check it out for sure. It's a great paper that we reviewed, which showed that it is much better and a much higher rate of pregnancy, live birth, if you do progesterone in oil and vaginal progesterone than if you're doing just progesterone vaginal alone, or even just progesterone injectable alone. Hi, Dr. V. They left you out, buddy. I'm sorry. Yeah, do you want some Kleenex?
I'm offended. Just let them know.
Just did my retrieval, and I have 4 blasts. Yes! How many transfers does it take for one child? Oh, that's from Mangolicious. I like that. Mangolicious. That depends on the number of normal embryos that you have. 3 normal embryos gives you a 95.2% chance of a live birth. 4 normal embryos gives you roughly a 98 point something percent chance of a live birth. So if you are getting, a pretty decent number of normal embryos, you probably are going to be successful in 1 or 2 tries if they use the right protocol for you. What is your typical FET protocol for someone with unexplained infertility? Do you recommend any tests? I do. We would even consider surgery for unexplained infertility. We don't just jump into doing FETs. So we use letrozole. We use lots of vitamins and supplements. We use aspirin. And then for unexplained, the 2 things that have been shown to be very good are 3 months of Lupron and letrozole before the transfer. And then as well, we use PRP for some of those patients because that's been really beneficial. Human growth hormone, Neupogen, HCG wash, and Viagra vaginally. All of those have been shown to be beneficial. Do I use all of them? Rarely. But we use some of them frequently in patients. So yeah, you can try any of those. Hello, Dr. V. What type of protocol meds would be best for recurrent implantation? Testing is best for recurrent implantation. Figure out what's wrong, then go from there. So sitting in front of me is a whole series of results from Fertility, where I go through them and I figure out what's wrong with the patients, and then we treat them and they do better. So don't go just to a protocol. Figure out what's wrong first. Doing multiple rounds to bank embryos using DHEA 75. Is it okay to be on it for 6+ months? 6 is probably okay. You're going to start developing male side effects, hair growth, acne, weight gain, if you're on it for too long. Does germ layer mosaicism cause Vactoril? That one is beyond me. I'm going to need to look that up. I'm going to write that down. Germ layer mosaicism.
Every word in there I've never heard before in that order.
Germ layer mosaicism cause Vactoril. I'm going to look that up. I have no idea. Talati81. Maybe you know. Is germ layer mosaicism more prevalent at 38+ years? Yes. The older you are, the more mosaics you will have. What should donor eggs be considered? I'm 48. Oh, when should donor eggs be considered? I'm 48, AMH 1.81. I don't know if it's picomoles per liter or nanograms per mil. If it's picomoles per liter, it should be considered. Dr. Sharma made a great point. She said, you don't have to jump into a donor egg. There are protocols that might work for you, but it's worth considering, I would argue. And so you have to know your options and make a choice that's right for you. Wow, she put in a lot of questions. My cousin had a child with Vactoril. Mine died at 11 days. Similar issue. Is it in my family? Most likely, yes. Wow. Do you recommend PGT testing for 38-year-old if only getting 1 to 2 embryos? Okay. This is a great question, guys. And the answer is we don't know. So there was a study we reviewed on the show from Bob Casper's group in Toronto and a good friend of mine, Paul Chang, who was with me and Pratty in Denmark recently, where they looked at whether or not it was beneficial to do PGT if you had a low number of embryos, which they defined as less than 3. And they showed that it was actually detrimental potentially to do PGT. 1 week later, in the exact same journal that published their study, they published the exact opposite study, saying that even if you only had 1 embryo, you should actually get tested. So in my opinion, I think if you're 38, you should get tested because you need to know what your moves are next if these embryos are not normal. Am I going to go to donor? Am I going to try again? if you put in embryos and it doesn't work, you're always sitting there going, was it the transfer? Was it my protocol? Do I have a reproductive immunology problem? Do I need to check my vaginal microbiome, my uterine microbiome? So I think it's more important to know if the embryo is normal, because that's the most important part. So I'm still favoring doing it, but we don't actually know. It's like a damn good question. Hi, Dr. V and Grandmaster T.
I'm a big supporter of that.
Yeah. Honolulu Mama. This is from Hawaii, man. We're getting out there. Do you use embryo glue for transfers? Does it provide better outcomes? We actually use embryo glue for all of our transfers, and we don't charge our patients for it. Most places do. And it does improve the transfer outcomes. We have a video on that too on our YouTube channel, so check out the embryo glue video. What time is it? Oh my God, what do you want to do, 9:15? 9:15, okay. What are your thoughts on continuing CQ10 and ubiquinol after transfer? Is it harmful? It's not harmful, you can continue. Can uterine polyps removal increase chances of pregnancy via IVF? Yes. The presence of a polyp decreases your chances by 50% and increases your chances of miscarriage by 100. Whew. I'm 43 and had 7 eggs retrieved today. Congratulations. My doctor wants to do fresh day 3 transfer. Thoughts? I wouldn't, because at 43, probably somewhere around 80 to 85% of your embryos are genetically not normal, and you need to know if your embryos are normal or not before you put them in. So I would say grow them to day 5, get biopsies, and do a frozen embryo transfer. The other problem is with 7 eggs, you've got a pretty substantial estrogen and progesterone level. You have the whole problem with endometrial synchrony, high estrogen levels, risks of small for gestational age, intrauterine growth restriction, miscarriages. I'm not a big fan of fresh transfers for people that are making more than 1 or 2 eggs. Hey doc, what are your thoughts on transferring early blastocysts on day 5? My thoughts are, why didn't they just wait till day 6 and freeze them on day 6? So it's probably fine, but you might want to shorten the amount of time you're on the progesterone, like do it in the early morning of day 5 rather than late in the afternoon. Can 2 people, wow, this one's good. And this is a Persian person, I think. Can 2 people just be incompatible in creating a child?
Wow.
Yes. So there are incompatibilities where your immune system overreacts to your partner because it doesn't recognize them. That's the whole basis of LIT and IVIG and all those things. And yeah, that can be a thing. So actually Fertility has developed testing for that with this KIR testing, where they're checking for HLA mismatches, and they already do it for DQ alpha. So yes, it is possible that you can have problems. Can it prevent you completely from having a child? No, but can there be problems? Yes. I don't think I've ever seen this many questions. I'm going to be answering till kingdom come.
These are meant to be rapid fire.
Rapid fire, yeah,
There's
thanks.
actual questions on here that are not rapid fire.
Should we take some of those again?
I'm just letting you know.
1 or 2? Let's do 1 or 2 from there. Quick one here. Chances of a fresh 5-day transfer being a week behind in development and successful pregnancy? Negligible, unfortunately. Sorry. Yeah.
I have surgeries on varicocele.
Okay.
One on the lower part of the ab and right above the testicles.
Okay.
But I still have one varicocele vein that haven't been removed, and my morphology is with 95% head defects. Any
Okay.
advice? We don't have in Bulgaria embolism.
Oh, never embolize for varicoceles. It's terrible for the testicle. All those little particles actually go in your testicle and it kills it. Yeah, I mean, I would continue getting the other varicocele vein removed. And the problem, in theory, with having the varicocele is that it overheats the testicle. So an overheated testicle should be cooled. And so all you have to do is cool them. How do you cool them? Sit on frozen peas. That's what we do. So we get something cold and we tell the guys to sit on it, and that improves it. When I say we do, I don't mean Tarek and I are sitting on frozen peas, but no. But yeah, that does work, and it works pretty well.
What is your estimated success rate for first transfer for someone who's 24 with endometriosis following your exact protocol?
70%. 24, maybe even higher, 70 or 80%. Depends on how bad your endo is.
Two-part Q.
Two-part question. All right, I'm ready. Part one.
Part one.
You know, this whole note writing thing is helpful.
I have no doubt
Yeah.
that the paper and pen was invented for a reason.
There you go. You're so dead at recess. All right, go for it.
Just had my first Clomid
Yeah.
with HCG trigger,
Okay.
IUI cycle, and I ovulated 7 days earlier than usual in natural cycles. Could the rapid development have compromised egg quality? Number one.
Yes. If it was faster than like 12 days. If you were ready by day 11, yes, that could probably compromise egg quality.
Now, there's question number two, but there's also a comment after question number two.
Okay.
And I think the comment deserves to be read out loud.
Okay.
Love this channel, especially the guy reading the question.
Aw, that's nice. Yeah.
Number two, I was on 100 milligrams per day.
Yeah.
Should I take less next cycle? AMH 0.91, 38 years old.
No, I would be looking at whether or not your FSH is high and your follicles are actually getting ready earlier than they're supposed to. So if you're starting your day 3, for example, with a 12 millimeter, you probably needed to start your Clomid earlier, in like even before your period. And there is actually a study that looked at starting Clomid before people's periods and actually showed it was better than starting it from day 3 to 7. So there's different options for doing that.
What is the treatment for a male that 2 different embryologists have said this is the worst sperm they have seen?
Okay. Actually, I was just looking at this. So number one, find a good embryologist. So like ours is amazing. Even when I give her the worst possible sperm, she gets 100% fertilization almost every time. So your embryologist is number one, the most important thing. Number two, you need to take vitamins. You need to make sure you're not smoking, drinking, or using drugs. You need to ejaculate very frequently, once every day or every other day. And then make sure that you are keeping the testicles cold. So like I said a moment ago, sit on frozen peas 20 minutes a day or twice a day for 20 minutes a day. The new thing, which is up and coming, and we're going to tinker with, one, we're going to get this laser light therapy to see if it improves the sperm, because there is some data that says that it does it, the red light sperm treatment. So we're working on it. And two, Viagra. So Viagra may be the savior of some guy's sperm. There is more and more data coming out showing that for men that take Viagra, their sperm can actually improve. So I would actually strongly tell you that it's easy and that that's a good thing to do. Now, it's probably difficult in these cases where we're giving guys Viagra to figure out if their sperm's improving because they're ejaculating more, or if their sperm's improving because of the Viagra. But I'm going to start looking at those studies, because I actually had a gentleman just on the weekend who had very, very bad sperm, horrible. And so we told him to start that process. And so I think that that's a reasonable, thing to consider for people that are, struggling with their sperm quality. We are 1 minute away from 9:15.
Not sure what to do with that information.
Is there like an endless? Is there an endless number of
Oh
questions?
yeah, it's
The biggest ever.
yeah.
Oh wow. Okay. All right. Do you want to keep going, or should we wind it down? Yeah. All right. Yeah. Tarek's giving me the my wife will kill me sign. So yeah.
I never give that sign. My wife kills me every day.
joke for everybody that's listening. Mervette, we love you, and we appreciate the sacrifice you make letting Tara come on the show every week. Yeah. How comfortable is that couch, man? You're gonna be
Sometimes the chair is all I need, you know. Sometimes we're optimistic with the couch.
yeah.
MOTS or MOT10? Recommended when using donor sperm for ICSI.
MOTS?
MOT5, sorry. Vision impairment.
I don't even know what that is.
MOT5 or MOT10?
No clue. No idea what MOT5 and
Oh,
MOT10
there goes
is.
that one. That was
Yeah.
an easy one for you.
No idea.
Hey, Dr. BNT,
BNT.
do you recommend human growth hormones if you have low-level endometriosis?
Yes. Yeah. Only for the immunological impact, because it can help. And as well, if you have low-level endo, typically you will have some diminishment in your ovarian reserve, and the human growth hormone can overcome that. So that's a good question. Are we done, or what are we doing? It's done. All right. Listen, thank you so much for joining us tonight. Thank you so much to Dr. Prati Sharma, who's a wonderful human being and a very, very smart lady. I'm not going to lie, not everybody in the fertility world is that well versed in the literature. I almost said not that smart. So is not as well versed in the literature. Dr. Sharma is a really bright lady that reads a lot. So listen, if you need good fertility care and you want to seek it out with Dr. Sharma, by all means, she will do a very good job for you. I hope you guys enjoyed the show. Let us know in your comments and your feedback what you guys think about doing kind of a traveling fertility factor fiction every couple of weeks, where we'll go and visit another doctor and talk to them about what they do and bring them on to have a lively debate about things. Let us know. Hopefully you enjoyed the show tonight. Thank you again to all of you for watching. We'll see you again next week on Fertility Factor